Okay, I think we can get started. Good morning. Welcome to Project Echo on substance use disorders and pain. Today's Ed will be talking about injectable buprenorphine and naltrexone. Just a couple of housekeeping things and one quick announcement, and then we will get going with today's presentation. So this slide here just states that everyone involved has no financial relationships to disclose. We're obligated to share this slide as usual. And then we're also obligated to share our usual funding statement side. We're funded through the State Opioid Response Grant, which comes from the Substance Abuse and Mental Health Services Administration, SAMHSA. And then that's subgranted out to Nebraska Department of Health and Human Services and then on to us. Okay, the usual process for CME certificates, just a quick eval survey. That'll be in the chat. Also, that'll come in an email. Um, and within an hour after the training this morning. Complete that quick survey and a certificate will pop up. As always, holler at me with an email if you have any troubles. Okay, I do have one announcement. And this happens to be a good time for this announcement. Last week, Nebraska Department of Correctional Services reached out to me. They're looking for Sublocade providers. So currently, Nebraska Department of Corrections is offering Sublocade for patients with opioid use disorder who are under incarceration. They're looking for providers outside of Lincoln and Omaha, I should say, outside of Lincoln and Omaha, who are willing to provide Sublocade treatment for these patients when they are released. So it's currently a very small number of patients, but the medical and social work teams at the Department of Corrections are just trying to set up a referral network. So if you're interested in kind of being part of that network, just shoot me an email and I can get you connected with some folks over there at Corrections. All right, that's all I got for announcements. We're going to let our Echo expert panel introduce themselves. Let's see here. Mary, would you like to go first?
Good morning, Mary Ellis. I'm a nurse practitioner, attorney in the Omaha and surrounding communities. I work a lot with drug addiction and treatment.
Thanks, Mary. Todd.
Good morning, everyone. Thanks for joining. Todd Stoll, I'm a psychiatrist, and um, I want to bring up one other thing that I usually don't. If you're interested in a kind of additional training that is you don't have to pay for it, and it's an excellent program. It's called Bridges, and you can either contact Will for that. It's a 2-day program, or it's on the Clarkson Foundation website. It's a funded program. It is a terrific training program called Bridges.
Yeah, I'll drop a link to that registration. There's a training coming up in Kearney. Sorry, Kearney already happened. There's one coming up in Omaha um, next week, and then in November in Lincoln. Okay, Stephanie.
Hi, everyone. I'm Stephanie Bennington, psychiatrist located in Chadron, Rapid City area. Nice to see you all this morning.
Thanks, Stephanie. And John.
Morning, everybody. I'm John Massey, and I am an interventional pain physician in the Lincoln area and other spots in the state.
Thank you, John. And let's see, Alex, were you able to get on? There he is.
I was, thank you.
Yeah.
Hey everybody, Alex Dwork, family physician in Omaha. I have a wide range of interests, including pain management, substance use disorder treatment, and infectious disease. Thank you all for being here.
Awesome. Thank you. All right, Ed, I'll turn it over to you.
Thanks, Will. Good morning, everybody. Does that look okay, Will? Perfect. Yeah, so hey, Ed Kaiser here, family nurse practitioner in Omaha, Nebraska. Excited to be with you guys. As always, thanks for joining us. So I work with a company called Ideal Options. So we're a big company, multiple states throughout Nebraska. I mean, throughout the United States. So 7 states, about 70 clinics. And we used to have a clinic in Nebraska, but we don't anymore. So sometimes I get questions of like, hey, are you accepting patients or seeing patients in Nebraska? I'm currently not with Suboxone, but I do some stuff with Vivitrol, which I'll talk about. So anyways, the training that we're going to go over today, we're going to talk about injectables, which I'm excited about, but I just want to give a quick shout out to the Ideal Option team, because a lot of the trainings that I help put on, they support a lot of the content that we initially put out, have been very generous with that. And so I'm thankful for their help in putting on some of these trainings as well. So yeah, we'll talk about injectable naltrexone or Vivitrol, and then we'll talk a little bit about Sublocade and Brixadi. Here's the quick agenda of just the slides that we'll be going over, kind of in order. And then again, if you guys have questions throughout the time, drop them in the chat. We'll try to leave a little bit of time at the end to talk about things as well. So this slide may be a little bit small, but I think it's helpful for you. It gives you just a high-level overview of what the medications are, and sort of the doses and frequency, and sort of the location of injection of these different medications, and if you have to have a oral medication on board first or not, and how much of that medication. Talks about times where like Vivitrol is contraindicated, again, if someone's using opiates or buprenorphine, liver disease, which we'll talk a little bit more about. Some of the recommendations have sort of changed on that. Storage of the medication can be important if you're keeping it on site. We do keep a lot of these medications on site. The other thing I want you to know too is you can contract with different pharmacies and actually have them do the injection for you. So if you don't want to be having these medications shipped to your office and deal with all the process of storing these medications, a lot of times you can find some pharmacies, especially maybe in the bigger cities, that will be willing to store these medications and actually give the injections. And that can be really helpful for patients. We'll talk a little bit about kind of typical patient profile with each medication, and then sort of the injection regimen for these people. So when we treat patients with opiate use disorder or alcohol use disorder, we do have sort of stages of care in our practice, which generally just means that initially when patients are seeing us, they're seeing us more frequently. And then as they become more stable on their buprenorphine, we start seeing them less frequency. And we sort of base that on the drug screening. And so what this beginning of this slide is saying is like, hey, even if patients are on injectable medications that they're getting like once a month, we still try to adhere to a stage of care matrix that allows us to see them more frequently, really for like a contingency management sort of profile of like seeing them more frequently if they're using other substances like methamphetamine while they're still using opiates. And so this just says that like, hey, even if we're giving them injection, we still want to see them on a pretty regular basis. We do really want to try to limit the potential waste of these injections. So if you do have these on site, you have a narrow window of giving these medications, at least we do. And that may be due to some of our accreditation stuff that we do, but we have like a 45-day window for a lot of these medications to give them from the time that they receive where we receive them at our clinic before we get them to the individual. And so can just be important of just like making sure that that patient is actually going to show up for their injection. Even though these medications sometimes can be manufactured, they're like able to be, they would last longer than 45 days. We're required to give them within 45 days. And then we'll talk again more about blood lab monitoring, but general recommendation is to monitor LFTs for most of the patients every 6 months. May consider more frequent in patients if they do have renal and hepatic disease, but in the absence of known moderate to severe liver disease, you don't have to do LFTs prior to initiation of the injectable buprenorphine or naltrexone for that matter. All right, so it's kind of some overview there, but let's go. Let me do this real quick. Okay. So talk a little bit about Vivitrol. Who's a good candidate for Vivitrol? Again, this is a medication that's FDA approved for opiate use disorder. Again, you can give a naltrexone or Vivitrol for patients who have not been using opiates for 7 to 14 days, and if they've tolerated a trial of oral naltrexone. So you do want to do the oral naltrexone before giving the injection. This is probably best in opiate use disorder for patients who are really highly motivated. If they're not interested or unable to get access to agonist therapy like Suboxone or methadone. Again, sometimes a healthcare professional may be in this situation, possibly a pilot or something like that. Another person that could be a good candidate is if they failed prior treatment with agonist therapy. I can remember like one patient that I've seen that like did not do well on Suboxone or Subutex or other medications like that, and so the Vivitrol was actually a good option for that individual. Um, and then if they do have co-occurring alcohol use disorder, this is a good patient population to consider because Vivitrol is indicated for alcohol use disorder as well. Another caveat is an alcohol use disorder patient who's motivated to maintain abstinence or to reduce their drinking. And we'll talk a little bit more about that in some of the next slides, but that would also be a good patient for the Vivitrol option. A couple of precautions for you. Again, contraindicated in patients who are on opiates, including buprenorphine. We do like to ensure that patients have a negative drug screen before we start them on the Vivitrol. Sometimes patients are using like alcohol and methamphetamine, and they don't think that they're using opiates. But again, a lot of the drug supply right now is laced with fentanyl, and so they may be getting a fair amount of fentanyl with their methamphetamine. And so we do want to make sure that they don't have any opiates on board. Really important that you warn patients for opiate use disorder that they're going to have an increased sensitivity to opiates. And this can increase the risk of overdose if there is a return to opiate use. Again, possibly a patient coming out of incarceration who was not on therapy like Suboxone or Sublocade. If they want to continue with Vivitrol or they don't have access to Suboxone, we just always want them to know that, like, hey, once this medication wears off, if you get in a situation where you are exposed to opiates or have a return to use, even if it's methamphetamine that's laced with fentanyl, there can be a significant risk for overdose in those situations. Always want to make sure that patients have access to Narcan if they have opiate use disorder. Again, if you give this too soon with someone with opiates, it can cause precipitated withdrawals. If there is signs of acute hepatitis, we'd want to discontinue this medication and then obviously monitor for depression and suicidal ideations. It can complicate things when you think about emergency pain control for surgery and stuff like that. There's some other pain options that could be available, but I'll let maybe Dr. Massey speak to that towards the end of the time of what options are available for these individuals if they do have a shot of Vivitrol on board and they get into a acute pain situation. Okay, common side effects of this medication. Really, for all of the injectable medications, there can be injection site reactions, nausea, vomiting, headache, insomnia, diarrhea, and then we talked about precipitated withdrawals and then depression and suicidality. Let's talk a little bit more about sort of hepatotoxicity because I think that gets a lot of concern for individuals if they're trying to start someone. Is like, hey, what's this going to do to their liver function? Is it safe to give it to them? This slide, I've referenced it in some of my other talks that I've done, but this is the PCSS, Provider Clinical Support System guidelines. And what the PCSS is it's a program that's funded by the Substance Use and Mental Health Services Administration. So we're talking about SAMHSA, and they were created in response to the opiate epidemic. And they do these education modules online, but the goal is to provide sort of evidence-based practice to healthcare professionals on outcomes and prevention of those at risk for treatment with opiate use disorder and other substance use disorders. It's also led by the American Academy of Addiction Psychiatry. And I did include sort of a link to their website in here, which you can look up. But essentially, what they're saying with this education is that it's not necessary, again, to obtain baseline liver function tests, including AST and ALT, total bilirubin, prior to initiating naltrexone. It may limit the opportunity to sort of treat those in need if we wait to get the LFTs first. It is important that you're aware of history of HIV, Hep C, Hep B, or chronic infections. Again, however, not recommended to check these chronic infections as a criteria for starting the medication. And then point 3 here is at present, there is no empirical evidence to support frequency of monitoring of hepatic enzymes. There are studies of HIV positive and Hep C positive co-infected persons receiving it do not indicate any changes in liver function tests warranting more frequent monitoring. As I mentioned, 6 months is sort of what we go by on trying to get our liver function tests monitored on these individuals. But again, not a reason to stop the medication if we don't get that or even initiate the medication. A couple more recommendations from them. If they're on any new medications, we want to know that when they, if it could affect their hepatic enzymes, and then inform patients to contact healthcare professionals immediately if they develop, again, abdominal pain, nausea, vomiting, fever, dark colored urine, clay colored stools, jaundice. Essentially, like, this is sort of what I go by when I'm treating patients of like, hey, do you have any significant history of liver disease, and are you having any, physical signs and symptoms of, and otherwise, if they're not having that, they're saying that like, hey, you can go ahead with this medication and prescribe it, and then we can try to get some monitoring done on the back end. If they are having clinical symptoms of severe hepatotoxicity, which is sort of outlined there and what that is, then we would have them follow up with a specialist and see if it's coming from the naltrexone, and if not, or the Vivitrol, and if not, they can continue the medication. This is a slide that I'm not going to play, but this is from the PCSS, and you can access it online. And essentially, it's just a specialist who's a liver specialist talking about medications for alcohol use disorder in the presence of liver disease and sort of what they recommend. So just sort of putting that out there is like, hey, this is a really helpful resource if you want to learn more from a specialist in the area. All right, let's talk a little bit about the dosing of the medication. So Vivitrol, very simple dosing process. It's a 380 milligram IM injection. You get it once a month. Again, must be abstinent from short-acting opiates for 7 to 10 days, and then long-acting opiates for at least 14 days prior to receiving the injection. And they should also have a COW score of less than 4. Essentially, we're just saying that we don't want patients in any sort of opiate withdrawal when they're getting the medication. Intramuscular injection, again, not IV, not sub-Q, alternate each side of the buttock for the injection. We do have to store this in a refrigerator, so it can be out for up to 7 days before the injection, and then we do want to get it out ahead of time before the patient gets there for about 45 minutes prior to administration. This is a relatively large amount of fluid and a pretty big needle, so we do pre-treat a lot of our patients with some sort of like icy spray or put ice on the area ahead of time, and then you do have to reconstitute this in the office. It comes in a combination where you got to put the fluid in there and shake it up and try to inject this slowly. Generally a 2-inch needle for most individuals, 1.5 inches if you have someone that's very thin. Another just video for you, which I'm not going to play, but essentially it just is sort of a administration video where you just can watch someone actually give the injection. Okay. I mentioned earlier that one of the patient populations that this can be helpful for is somebody who's using alcohol but trying to cut back on the alcohol. So what this slide is just a summary of the sort of the findings from the Vivitrol company where they've done studies. And essentially the takeaway on this is that patients who are still using alcohol can have a 25% reduction in heavy drinking days per month. I want to tell you a quick story about a patient that we've seen recently. So I saw this 25-year-old patient. She was a female, came in to see me. I think she was in Washington. And essentially, she was just coming in for alcohol treatment. She's been drinking 1.75 liters every 2 to 3 days. So that's about 40 standard drinks. When she came in to see me, her BAC was like 0.22, so almost like 3 times the legal limit. She was there with her mother, and she was being really supportive of the patient. And so I just talked to her. I said, hey, here's your options for alcohol use disorder treatment. We can try to go through the detox process and try to get you on some Vivitrol or Naltrexone, or we can try something more of like the Sinclair method where you take the Naltrexone an hour before you drink. Again, just trying to make whatever options are available and allow the patient to choose what they want to do. So she's like, oh, I want to try the Naltrexone method. I've never tried something like that before. So we started on the 50 milligrams of Naltrexone an hour before alcohol use. And this patient came in very consistently every single week, but we did not see any significant reduction in her alcohol use really for the first 2 months. And so what we did at that point is we increased her Naltrexone oral medication to 100 milligrams a day. And we tried that for a while. And 2 or 3 months into this, it can take like 4 to 6 months for patients to really see really great results. But 2 to 3 months into this, we're starting to say like, hey, maybe this patient really should transition more to like detox and, maybe just like try to go that route and trying to get off of her alcohol. But what we decided to do is to go ahead and give her the Vivitrol injection about 2.5 months into her treatment. And so we gave the Vivitrol injection, which that way we know she has the medication on board and she's continuing to drink. And about 3 weeks later, we got our first negative breathalyzer test at her visits when she was coming to see us. So that was like the first time that we've seen like an actual improvement in her alcohol use. She is reporting that she's drinking less, so she's out to like I want to say handle lasting her like 5 days now. But it'll be interesting to see what happens with this individual. But just highlighting that, hey, we can use Vivitrol also to reduce alcohol use. This is kind of a very unique case, but hopefully I'll be able to give you more information on that in the next 3 to 6 months and see how she actually ends up. This is just my current plug. I mentioned I don't have practice in Omaha anymore because Ideal Option closed in Omaha, but I did launch Kaiser Consulting. My whole heart in this is to offer naltrexone or alcohol use disorder in a remote setting for individuals. I've had questions from people after doing trainings before, like, hey, are you seeing patients yet for naltrexone prior to substance use? And I haven't been, but I am now. But I also just want to say, hey, my heart in doing education is not for me to be seeing patients here. It's for every provider that's out there to be offering naltrexone or Vivitrol for patients with alcohol use disorder. But I do want you to know that this is available if it's helpful for you in your practice or someone that you know. All right, so that's the Vivitrol side of things. Let's transition now and let's talk a little bit about Sublocade. So again, who's a good Sublocade, who's a good candidate for Sublocade? There are some benefits over the sublingual buprenorphine. One of them is that it's a once a month injection versus the daily dosing of this medication. And because the sustained serum levels of buprenorphine are higher in the Sublocade, and that's sort of shown on that graph. I know it's kind of small there, but it can reduce drug-liking behavior for individuals. Suboxone has been known to cause dental decay in individuals, especially if they're on the medication for a long time. We're supposed to educate patients if we start them on Suboxone about this. And then obviously, if we're just getting the injection on board, we don't have to worry about that. This can improve medication adherence, especially if there's transportation or mental health issues that are causing people that have issues coming to their appointments or taking their medication. And then this does obviously lower the risk of diversion or non-medical use of buprenorphine as we're just giving the injection on site. There are some benefits over Brixadi, which we'll talk about next, but one of the benefits of Sublocade over Brixadi is that it does have a longer half-life. So the half-life of Sublocade is closer to 43 to 60 days, where the half-life of Brixadi is closer to like 19 to 25 days. And so if a patient we get this question a lot of like, how long do I have to be on Suboxone and can I taper off the medication? If a patient is coming and wanting to taper off the buprenorphine and they have the option between Brixadi or Sublocade, we'll generally lean toward the Sublocade as an option for injection to try to help them wean off. And this is just kind of due to the longer half-life of the medication. But either one is fine to use if a patient wants to use injectable to wean off of the medication. Some of the precautions with this, so, because it may result in a higher sustained serum buprenorphine level relative to the sublingual medication, there is more of a risk for CNS depression, especially if you're combining these substances like alcohol or benzodiazepines. So just something to be mindful of, but not something that should scare you away from prescribing the medication. This can cause neonatal opiate withdrawal syndrome, as do all products of buprenorphine, so that's not really new. But the higher serum levels can pass into the breast milk. So just something to be mindful of if a mother is breastfeeding. This is not a medication that is used in pregnancy. It's not contraindicated in pregnancy, from what I understand, but it would have to be in correlation with a specialist if somebody would stay on it. But again, generally not used in pregnancy. And then hepatic impairment may slow metabolism of the medication, so that would result in higher plasma levels of the buprenorphine. So if a patient does have moderate to severe liver disease, you want to discuss if we're going to continue this medication or not. There's some guidelines that we operate by as far as LFTs, and then obviously if there's presence of any signs of liver failure. With all individuals who are on any sort of buprenorphine product, we do recommend that they have access to Narcan. Again, in these individuals, what the concern is like if they have the buprenorphine on board and then they add something like a benzo or a large amount of alcohol and they start to get CNS depression, you can give some Narcan and reverse that, but you can't reverse, obviously, the alcohol or the benzos. And so, again, very low population that's going to have problems with that. but we do want to make sure that all the patients have access to Narcan. Common side effects of this medication, again, the injection site reaction is possibility, headache, constipation, nausea, vomiting, not different from the regular medication. Patients should not drive or operate heavy machinery or perform any other dangerous activities until they know how the medication affects them. So this is primarily during the initiation of this medication until they're on it and they know sort of how they feel. I get the question a lot about can patients drive on buprenorphine? Can they drive on Subutex? Or can they drive on Sublocade or Brixadi? This is sort of a bunch of recommendations from different people. So the FDA labeling on the Sublocade is that it can have potential sedation, dizziness, and impairment. Don't drive until you know the effects of it. SAMHSA says that driving may be prohibited for stable patients, but caution is critical during sort of, again, the induction or if we're titrating the medications that can interact. ASAM says patients on stable buprenorphine dose without sedation or cognitive impairment may be considered safe to drive. And then the DEA, DOT, Department of Transportation says for certain jobs, buprenorphine must be disclosed and medical clearance is required for safe and sensitive positions. So I don't specifically know about like DOT physicals for patients that are on Sublocade because we don't do any of the DOT physicals. But I know that they have to disclose that and then they have to get clearance if they are going to be able to do that. Okay, starting Sublocade. So again, patients should be initiated onto the sublingual medication, both to assess for hypersensitivity and to reduce the risk of precipitated withdrawal. Prescribing guidelines state that you should be on the oral medication for a minimum of 7 days. There are some newer studies out there, and I went to the ASAM conference this year where people are starting to do more of a rapid induction on the Sublocade, but we are not currently doing the rapid induction. So they should be started on, they should be on at least 8 milligrams of Suboxone, generally speaking, before they start on the Sublocade dose, and we'll talk more about that in a second. When patients initiate on a Sublocade, sometimes it takes a while for this medicine to build up in their system. And so it is okay to supplement sublingual buprenorphine on a short-term basis. Generally speaking, when we're supplementing on top of Suboxone or Brixadi, we don't go above 8 milligrams a day, sort of during that titration period. But we prescribe patients to have the ability to take a little bit on top of that. And that can actually ease a lot of concerns about patients who are stable on Suboxone dose and talking about transitioning. They're very fearful of like having withdrawals, getting on the Sublocade. And so helping them understand of like, hey, we can give you oral medication to help during that initiation process can be really helpful for those individuals. Again, sorry about the smallness of this slide, but essentially what this is determining injection dose. And so generally speaking, stable patients who are on 8 to 18 milligrams of buprenorphine, we'll start them on the, okay, sorry. So anybody above 8 milligrams, we'll start them on the 300 milligram injection. Generally, they'll get 1 or 2 of the 300 milligram injections, and then it drops down to 100 milligrams. And that's just sort of the standard way that the medication is giving. If a patient is on greater than 18 milligrams, so maybe up to 24, we do have some patients that are higher than that. We start them on the 300 and give a couple doses of that, and then we'll assess to see like, hey, are they still having like breakthrough withdrawals, or are they still needing supplemental medication? And if so, we can continue them on the 300 milligrams, I think up to like 6 injections, and even longer than that if we can get approved through insurance if they need it longer. If a patient is on less than 8 milligrams of Suboxone at initiation, we do sometimes start these patients on like 100 milligram injection. But again, this is not really the indicated way to do it, but we've done some of this in our practice to help patients get on it if they're on lower doses, but you do need to be cautious about that. Again, so Sublocade administration, again, it's a abdominal sub-Q injection, again, not intradermal, not IM, sorry about that, and not IV. You do have to leave the Sublocade out to room temperature for 15 minutes prior to injection. We do pre-treat this area with the ice or the freeze spray, try to give this injection slowly over time. it's nice if you have like a table you can lay the patient down on, but a lot of times we've seen this just given as a patient sort of leans back in their chair. They can get the injection that way. Again, it's a larger volume of medication, so it's 0.5 mLs for the 100 milligram and 1.5 mLs for the 300 milligram. One of the things that patients don't love about Sublocade is just that it is a relatively painful injection. So patients that don't like getting shots or don't like needles sometimes will shy away from the Sublocade because of that. Again, another video for you that I won't play, but just has the administration of the Sublocade, and we can get you those slides if that's interesting to you or helpful for you. One of the issues that you'll run into when you're giving Sublocade is the delay in dosing for individuals. So what this slide is sort of showing you is the same information just in two different ways. So if a patient is due for their next injection and it's less than 14 days, or another way to say that is if it's less than 42 days since they last got their injection, essentially two ways of trying to say the same thing. Generally, if they're at a therapeutic level, we'll go ahead and give that next injection of Sublocade without adjusting any dosing. If the patient's, so 14 to 28 days since their last missed injection, or 42 to 56 days since their last actual injection, if they're at a steady state and likely therapeutic, we don't necessarily need to change anything. But if they haven't been at a steady state, if they haven't had like 2 or 3 injections of the medication, we may want to reduce their dose at that time. Or the other thing that we can do is give them a test dose of the sublingual 8 milligram buprenorphine. And then if they're not having any sedation, we may recommend go ahead and go along with the dose of the medication at that point. If we get outside of that window, so if we get like greater than 28 days since the missed injection, or essentially almost 2 months since the last injection, likely we will reduce the dose of the, or we may drop it down to the 100, or we may reinitiate that patient on the sublingual buprenorphine before we recommend getting the Sublocade treatment on board again. Again, if thinking about like, hey, what is steady state for most individuals? So if they're on the 300 milligram and just continuing the 300 milligram, it says that steady state is reached after like six months of the dose. So again, if somebody's on that and they're late, it'd be fine to drop them down to the 100 if you had access to that medication. Generally, for other individuals that we're dropping down after the second injection of like the 300, 100 regimen, those patients are going to be probably at therapeutic state. And so if they fall inside one of those windows, if they're a little bit late, we'll go ahead and give their next 100 milligram injection to that individual. Again, I mentioned at the beginning that we use Sublocade a lot to wean people off of medication. So if a patient does decide to discontinue their Sublocade, they should be monitored for a few months for signs and symptoms of withdrawals and treated appropriately. Withdrawal medication is needed. The peak withdrawal may emerge as anywhere between 8 and 24 weeks after the last dose is administered. And then after steady state has been achieved for 4 to 6 months, patients who have discontinued Sublocade, they may have detectable levels of buprenorphine for up to 12 months or even longer, which again is why this medicine is a good one for sort of tapering patients off the medication, because it can leave their system relatively slowly. Always is good practice to document why we are discontinuing buprenorphine or Sublocade. And then we always want to provide relapse prevention education for the individual and make sure that they have access to naloxone. Again, patients just need to understand that when they have the buprenorphine on board, not only is it helping with cravings and desire to use, but it also is having a blocking component on that opiate receptor because it sits so tightly on that opiate receptor. And so once this medication wears off, if there is a return to use, it does open them up for concerns about overdose in that situation. So this is one of the sort of models that we use to taper patients. So essentially, if they're on a maintenance dose of 300, we're going to drop them down to 100. And then we're going to kind of see what they want to do. The way that I've probably seen us do this the most is at the 100 milligram injections, we'll go do a 4-week interval, which is normal. Then we'll go out to 5 weeks. Then we'll go out to 6 weeks. Then we'll go out to 7 weeks. And then we'll go to 8 weeks. And then we'll stop the medication. Again, when you stop the medication, you can consider giving some like withdrawal medications to help the individual. And again, patients are never sort of stuck with being done with the medication. If we get to stretching it out and they're not feeling well and they want to stay with it, we can bring it back closer together. Or if they decide they want to get back on the oral medication, that's fine to restart that as well. But that's just one of the models that we use. This is a bunch of sort of frequently asked questions. And again, I just think these are helpful sort of as a resource for you. But I'll read a couple of these to you. So when is it reasonable to continue a patient on Sublocade 300 for their maintenance dose? So we're talking about like into their third injection and beyond. And again, essentially, if they're on the 300 monthly, if they're stable on high doses of buprenorphine before that, or again, if they're continuing to experience any cravings or withdrawals or illicit substance use in that first few months, it may be a reason to sort of continue them on the higher dose of the medication. What if a patient is on 300 milligrams and they continue to complain of symptoms of withdrawal? Again, we will supplement individuals with buprenorphine on top of the 300, not above 8 milligrams. But if they continue to have withdrawals after a few months, we may consider like discontinuing the Sublocade and going just back to the sublingual medication if they were doing better on that. We can talk about transitioning to methadone. We don't do a ton of transitions for directly between like Suboxone and Brixadi and back and forth, but we could like have a period of time where they're on the oral and then try a different form if that's helpful. So again, how do I manage patients with ongoing meth or alcohol use? Again, you can still continue the Sublocade in these individuals. We would just generally try to see them a little bit more frequently for some contingency management and trying to encourage them to avoid those substances. Again, these are monthly injections, so it's really hard to get a patient to come in 2 weeks after you give them a month's worth of medication. But sometimes what we've done is like not order their next injection until they come to their second appointment in an attempt to just try to encourage them to come to appointments in those ways. So again, I'm not going to read all of these to you. I have a couple of slides of sort of frequently asked questions. But I do think that they're sort of helpful resource for you if they're if you're starting patients on them. One that I will read to you is this bottom one. It says, when initiating Sublocade, should patients take their sublingual buprenorphine on the day of the first injection? And generally speaking, we say don't take it on the day of the first injection. We want about 24 hours from their last sublingual buprenorphine dose before we give the medication. But with that said, like if a patient does take their medication that morning, we're still going to give the injection. We're not going to not give it to them. But that's sort of what we would recommend. All right, I'll let you guys read over those at your leisure at some point if you want. Let me see if there's any other good ones here. Oh yeah, methadone to Suboxone, don't do that. It does not go well for individuals. If they're going to travel, just be mindful of that. Again, if it's been more than 14 days, you can refer to that form that we have there. And then oh yeah, this is a decent one. Should I administer Sublocade to an intoxicated patient? Again, the peak plasma levels it takes about 24 for the Sublocade, 24 hours after injection for the Sublocade to peak. So if you have the access of like a breathalyzer test and someone has, a positive breathalyzer test, but they're able to give consent and they're with it, we will go ahead and give an injection in that situation. But just want to be mindful of sort of the onset of that. I don't know how I drew that blue line in the middle here, but I'm gonna have to leave it because I don't know how to get rid of it right now. All right, let's talk a little bit about Brixadi, and then we'll try to leave a little bit of time for some questions here at the end. Okay, so who's a good candidate for Brixadi? There's some benefits over the sublingual buprenorphine. This does have weekly and monthly injections, and it has dose variations that are available. Again, it does reduce drug liking, similar to the Sublocade. It's really convenient for the weekly and monthly due to travel or work schedules. It does improve medication adherence and then lowers the risk of diversion. Potential benefits over Sublocade, again, weekly and monthly injections, multiple dose strengths, which we'll talk about, much less injection discomfort. So this is a much smaller needle, much smaller amount of medication, more like the experience of getting a flu shot. And so individuals really like the Brixadi from that standpoint. if they're starting on Brixadi without having the oral medication, it can be a good option for them. If they're inconsistent or ongoing illicit substance use or alcohol use. And then that's for the Brixadi weekly. For the monthly, it's just that people are stable. We would start them on the monthly. I'll talk a little bit more about starting patients on Brixadi without any oral medication on board. Precautions for Brixadi is just a similar concept to the precautions for Sublocade. There's a higher serum buprenorphine level. So again, CNS depression. If there's alcohol or benzos on board, neonatal opiate withdrawal syndrome, and then passing into the breast milk. Hepatic impairment may slow the metabolism, resulting in higher plasma levels. We sort of talked about that. It's very much the same. And then one really important thing with this medication, you cannot take 4 of the weekly injections and give them all at once to make a monthly injection. That's not how the medication works, so don't do that. The needle cap does contain latex, which is good to know. So if a patient does have a latex allergy, and then we always want to ensure again that patients have access to naloxone with this medication. Again, side effects of the medicine, there is some injection site pain, headache, constipation, nausea, vomiting, little redness, fatigue. Again, very similar to the Sublocade common side effects. So if a patient is generally we want to initiate patients on sublingual buprenorphine prior to administering the Brixadi. And if a patient is on the sublingual bup, we can do either Brixadi weekly or Brixadi monthly. And the dosing chart there is there for you. So again, if someone's on less than 6 milligrams, the Brixadi 8 milligram weekly is what we would start this individual on. They don't have a monthly dose of that in the Brixadi, but it is nice that they have a much smaller dose for patients that are on lower doses of buprenorphine. And then again, respectively, 8 to 10 milligrams of buprenorphine, we start them on the 16 milligrams weekly or the equivalent 64 milligram monthly injection. Sometimes when patients have higher levels, like so if they're on 12 to 16 milligrams of Suboxone, in some individuals, and we'll talk about this, it takes 3 or 4 injections of Brixadi to get to steady state. And so we have seen in some individuals going to the higher dose, if we have concerns about their high fentanyl use, that they're actually going to do better on a 32 milligram. If they've been on 16, then 24. But again, that's just maybe some of the things that we've seen in practice, but these are the recommended doses across the board for individuals. This is the sort of delays in dosing. You have the same issue with individuals not coming in, and it's a similar slide to before, but days since missed injection, so less than 3 days or less than 10 days on the weekly, you can reduce it. It may reduce the plasma levels, and so we may reinitiate with some sublingual or at a lower dose of Brixadi weekly. And then again, if the days are greater than 28 since the missed injection or greater than 56 since the last injection, we may reduce the level of this. And it's easier to reduce the level, especially if you have it on site with that. I think you can get this weekly injection up to like 2 days early too. So there's a little bit of wiggle room for individuals on getting that medication. This is the administration. Subcutaneous injection only, again, not IM, not IV. There's multiple injection sites, as you can see. It is worth noting that the upper arm is associated with a 10% lower plasma levels. So initially, like for the first few injections, we wouldn't recommend that, but just something to be mindful of if that's where we're giving the injection. It's a really small needle. You do not have to keep this medication refrigerated. You can pre-treat the area with some ice or freeze spray to help with the pain of the injection. And then discontinuing this. So if a patient has been on Brixadi and they want to stop the medication, if they've gotten to sort of steady state, which can happen, I think steady state with Brixadi is 4 injections. So that's 4 of the monthly injections or 4 of the weekly injections. So a lot of times when we're initiating patients, give them 4 of the weekly injections to get them up to therapeutic level, and then we can switch them over to the monthly, and they'll generally do better with that. If we're trying to discontinue, we'll generally try to lower that dose of medication, whether it's the weekly or the monthlies, down to the lowest one. And then we can start spreading that out a little bit longer and then just discontinuing the medication as patients are coming off of it. Again, a little bit of like frequently asked questions related to the Brixadi. A lot of these are very similar to the Sublocade questions that we did. Again, when initiating, should patients take their sublingual on the day of the first injection? Generally not, but again, it's not going to stop us from giving it. Special considerations from weekly to monthly injections. Again, we talked a little bit about steady state after 4 weekly injections, and so you can just transition up the next time. Oh, this is the one that says like, hey, when can I give the Brixadi weekly? And it says 2 days before or after the weekly interval is fine to go ahead and give the injection, and then monthly up to 7 days before or after the injection, it's fine to just continue with the injection. What if a patient's on Brixadi and they want to transition to sublingual buprenorphine? Again, generally around the time of the Brixadi wearing off, you can start to give them some oral medication, and then they can slowly just get back onto their regular dose. So again, for the sake of time, I'm not going to kind of read through all those, but I hope that those are helpful kind of frequently asked questions that you guys can kind of look over and can be helpful as you're initiating onto it. One just quick thing, I know this slide is blurry, but we do, this is my last couple slides here for you. So we do some direct initiation onto Brixadi. You don't have to have a test dose of 4 milligrams on board, and you don't have to be stable on sublingual buprenorphine before doing this. And so this is sort of our protocol for doing that, but it's nice for certain individuals that that are unsteady, or they're not coming to their appointment, or maybe they're in the emergency department. There is a way where if they start to get into some withdrawals, what we recommend like 12 hours from their last fentanyl use, but if they've tolerated buprenorphine before, or if they've been on an injection before, we can just do a direct initiation onto the Brixadi. And again, just another way to try to help people get on the medication. This just sort of talks about, it's really small, but the Brixadi sort of onset peak does take a little bit of time. And so again, if a patient is starting to get into a little bit of withdrawals, we give the Brixadi injection. By the time that's peaking, the more of that fentanyl is wearing off, and sort of they're able to transition on the medication pretty well. So again, a little bit probably higher level, but just want you to know that it's an option for individuals, and there's help around trying to get someone started in that situation. All right. I am done with my PowerPoint here, open to questions. Haven't been monitoring the chat, so.
Yeah, any questions for Ed? There was a comment from Kelly just about your slides being helpful, good algorithms and recommendations. So yeah, those slides will be coming out later this morning in that email. Those look like a great resource. And yeah, feel free to unmute or drop some questions in the chat. We've got 10 minutes.
I was going to put Massey on the spot if he's still there, about sort of pain management, post-Vivitrol injections, if he has recommendations on that too, if we don't have other questions.
Question about your experience with insurance covering Brixadi? Do you know having challenges there?
Yeah, that's a good question. So the majority of the patients that we are treating have sort of like state insurance, so a lot of Medicaid. It really has been state dependent. Some states are very kind to Brixadi and willing to do Brixadi or Sublocade, Brixadi or Sublocade. Some of them prefer one over the other, but generally speaking, for the states that are approving it, there's not a huge issue with insurance covering it. Sometimes we do document, so like if a patient is transitioning from oral to any sort of injection, like we ask questions of like, hey, why are you making this transition? Like, is it because you're having dental issues? Are you thinking about maybe possibly tapering off of the medication in the next, 6 to 12 months? Are there side effects associated with it? And again, that I think is helpful for the insurance company to have. So I'll generally document something along those lines for the individuals. And a lot of times the patient can be sort of coached in that a little bit of like, hey, I haven't done well on this medicine, or like I maybe do want to taper at some point. Okay, great. Even if that changes, we can still say that you're thinking about coming off the medication in the future as well. So
Great.
good question.
John, are you on right now? He sometimes I know he's in the clinic. He may have to
Yes,
step away.
yes,
Oh
I'm.
yeah. Okay. Yeah, Ed, do you want to pose that
I was trying to
question?
put you on the
See.
spot, John, but the question that I was framing up for you was like, hey, a patient's on Vivitrol injection and now they have an acute pain situation. A lot of people get worried about that. How are we managing that in both the outpatient and inpatient setting for those individuals to sort of like calm their
So,
nerves about getting the
so
medicine?
it's yeah, it's really hard to specifically answer that question, but what I like to say to people is, yeah, we may need to use a little different kind of an idea, but we have plenty of options that we can do that. We just really de-emphasize the role of oral opioids. The newer medicines like Journavx, things like that, which are equal analgesic and non-opioid. We have little procedural things, just basically non-opioid management. And then if we have to, then we cross that bridge. But usually we're very successful managing almost any range of unexpected need for pain management.
Thanks.
Thanks.
I think that can just be really a helpful thing to reassure
Yeah,
patients like, oh,
you
I'm
always
worried
have
about
to be prepared to answer that question. You're right.
yeah, absolutely. Thank you.
Let's see. Alex asked, I don't know how to pronounce that. That drug you just mentioned, any actions with buprenorphine?
Are you speaking of Journavx?
Journavx, yes.
Not a
Does
problem.
Journavx have any
No,
action?
no,
Yes.
no interactions. No, no. You can use it with. Yep.
That's
Okay.
really good to
Very
know.
expensive.
John, is it also something that's super expensive and not covered by insurance, or do you get a lot of like prior auth pushback? And is there any
Yes.
accessibility for uninsured patients
Yes,
at
for
this point?
sure. Yes, for sure. If you're doing any kind of, so I primarily use it for postoperative management in patients that maybe are on buprenorphine or just we don't want in part of the ERS, try not to use any opioids. Um, and yes, there's pushback, but we think of it as an acute medicine. And right now, for non-Medicare, non-government payers, you can get they'll give you a they'll the reps will give you a copay card, a coupon for that, so you can get them a week or 5 days worth of that medication without any upfront cost. And in that period of time, you're working through the prior auth like so many others. Yeah, but it is prohibitively expensive if they're paying for it.
Any other questions this morning for Ed or others on the Echo team? I did drop a link in the chat just now if you want to grab that evaluation survey and your certificate. That'll also be coming out in an email. I'm not seeing anything else, so maybe we will. Oh, I see. Mary had a question. Sorry. Is there a list of surprises? Mary, can you maybe elaborate, or maybe others know what you mean by that? Oh, sorry, providers. Yeah, that's a good question. A list of like Sublocade or Brixadi providers. Um, I don't know of one. Does anyone on the Echo team know of one?
I don't know of an updated one. I think there are some like there used to be some lists of like people who had done the trainings on Bupe and stuff like that. But as far as like
Hmm.
who's actually doing the information, that I feel like it would be a helpful tool if we could put something together, even if people are, hey, I'm willing to do this with some help to be a provider for that. I think that would be helpful.
Yeah,
Yeah, yeah.
sorry, that chat was just I was having trouble typing, so
No problem. Thanks, Mary. Yeah, we'll look into that and see if we can find anything. Let's see. We have one question here. How do you get around the exquisite pain of the Vivitrol injection? Many stop using it because of the prolonged local pain.
Yeah, I mean, I've given this injection a handful of times, and it's a big injection, and it is painful for the individual. So honestly, it's one of those things of just like, hey, benefits and side effects of the medication. So like, if it's continuing to cause a lot of, I mean, obviously we're trying to alternate sites with the injection and give it slowly and some of that. But if it's an issue where it's just like, hey, it's too painful and they don't want to continue to do that, we can always just transition back to the oral medication as well for a period of time. So that's all I have to say on that, unless someone else on the Echo team has recommendations on the pain, John.
A couple times, so we use the lidocaine for the Sublocade, and that works very effectively. Um, and so we've used a little bit of lidocaine before, and it doesn't work right because it's the intramuscular part of it that's achy. But I think psychologically it kind of helps the patient hear, well, how about if I numb it first and then we do it? My guess is it hurts just as much, but they give it less agency. They just feel like it's better. So we let people choose that if they're concerned.
Good idea.
Okay. Well, we will call it a day there. We'll be back in 2 weeks. Stephanie's doing a talk on psychosocial challenges with SUD treatment. So that'll be an interesting one. And hope to see you all back then. Have a good day, everybody. Oh, and then Echo team, if you guys want to switch to that other link, we'll do a quick team meeting now.